And now, it is my pleasure to introduce our morning keynote speaker. From its inception 10 years ago, Dr. Main has directed the California Maternal Quality Care Collaborative, more affectionately known as the CMQCC to most of us. He also chairs the California Pregnancy-Associated Mortality Review Committee. Currently, Dr. Main is a professor of obstetrics and gynecology at Stanford University, and he has received the very most prestigious ACOG Distinguished Service Award for his work in quality improvement. Ladies and gentlemen, I give you Dr. Elliott Mann.
Thank you, Dr. Box. It's been very warmly welcomed here in Indiana. My topic today is really going back to the roots of maternal child health programs, which is healthy mothers is the prerequisite for healthy babies. And I think we've taken our eye off of the prize a little bit over the last decade, several decades. As you'll see in a moment, the maternal mortality rate has risen, and the rise also in maternal complications can certainly negatively impact our baby outcomes as well. Let's see. What I'd like to start, though, with is that I did confess to Dr. Box that she was not the first Indiana Commissioner of Health that I've met. I had the pleasure of being in Washington a number of times. Washington is how my grandmother from Hammond, Indiana, taught me how to say it. But I learned also that when you become the Surgeon General of the United States, you're actually an admiral in the Public Health Service. So how can you be a general and an admiral, but it's having it both ways? But Dr. Adams gave the keynote address for the federal HRSA Maternal Mortality Summit that I also spoke at. And he's proven to be a very effective speaker, very passionate, all the makings of a good politician, it sounds like. But he led the meeting in a very positive way, and really his focus, helping to focus national efforts on our current problem of maternal mortality that you'll hear a lot more about today. So this is the data. What we've seen is that maternal mortality has risen in the United States, whereas every other industrial high-resource country has fallen in the period from 1990 to 2015. The CDC calculates it a little differently than the National Center for Health Statistics, and their pregnancy mortality surveillance system is lower, 17 versus 26 per 100,000, but it's also an almost identical type of rise. So maternal mortality has risen 50% or more. Maternal morbidity has risen 100%, and cesarean birth rates have risen 50% in the same time period. So clearly there are, shall we say, opportunities for improvement here. So what are the major causes, underlying medical conditions that lead to the deaths in mothers in the United States? This is a composite of multiple studies, and what we're showing here in the first red column is the mortality rate, which is roughly 1 to 2 per 10,000 births. And you can see the leading cause is actually cardiac disease at the bottom, and then the other leading causes fill in together, roughly the same numbers of embolism, infection, hemorrhage, and preeclampsia. If you look at ICU admissions, which is 10 times more common, 1 per 2 per 1,000 births, you start seeing hemorrhage in hypertensive disorders becoming dominant. And then when you look at the CDC definition for severe maternal morbidity, now it's up to 1 to 2 per 100. And this is now almost 80% is driven by hypertension and hemorrhage. So we looked very carefully at these when we conducted our maternal mortality reviews, and really we're trying to look at what were the quality improvement opportunities, not just the demographics of the death, how many were Black, how many were older or younger, or how many were of lower socioeconomic status, but what could we do in the health system to really affect the care? They were the most common preventable causes of maternal mortality. They were the most common causes of severe maternal morbidity, and they had high rates of provider improvement opportunities characterized by denial and delay. And we're going to see some videos in a moment highlighting this. So there's been a huge amount of media in the last year on maternal mortality in the United States, and it reached a climax 2-3 months ago. USA Today had a series of articles really focusing on this, and this was one that got a huge amount of attention around the country, provocatively, calling hospitals know how to protect mothers, and we're going to talk about safety bundles and some of the AIM and national projects on this. Hospitals know what to do, but they're just not doing it. And that really made a lot of folks around the country sit up and pay attention. So I'm going to show a video as part of this series here that is, you can find these on the USA Today maternal mortality. If you Google that, and there's a series of 28 of these, I'm going to show you 2 over this morning. So if you could have the first video of Danielle Bell.
I never got an answer to why I almost died post-delivery, having my second child. And now that I'm pregnant with my third, I'm terrified. Next thing I know, I felt a gush. And then I said, I think I'm bleeding. And so the nurse lifted up the sheet, and then she called for the crash cart. And it all went downhill from there. How bad is it? She says, I'm not gonna lie to you. It's bad. And at that point, I told her, I have 2 little girls that I have to raise. I need you to do everything you can to save me, because I have 2 girls that are counting on me. Don't hold out on me because you think that it's too bad to tell me. So when the nurse was, initially when she didn't respond to my question about the dizziness, I felt like you were too busy for me, or you felt like I'm just complaining or something like that. But then once I had the hemorrhaging and this is all going on and I'm asking you questions about how severe it is and you're still not giving me an answer. At that point, it wasn't about me per se, but at that moment, all I could think of is I have just had this beautiful little girl. She has to go home with the mother. Not knowing the reason why I had these complications the last time terrifies me. I'm at the point where with this pregnancy, I'm past my halfway mark. I think I have like 17 or 18 weeks to go at this point. But I can't give too much thought to it because I'm terrified that I won't walk away from it. My name is Danielle Bell, and I am one of the 50,000.
Each of these stories have been very touching. And when I presented this to the California Hospital Association membership 2 weeks ago, it was amazing the number of nurses and physicians in the audience who stood up and said, I've had similar experience personally with not knowing what's going on, not being told, not being listened to. And we'll see another example of that in a moment. So the way we've approached this in California and are gearing this up for national efforts is to do a public-private partnership with 4 basic principles. We want to link public health surveillance data into actions. Maternal mortality reviews are starting here in Indiana. They are very powerful tools to mobilize multiple constituencies, a broad range of public and private groups. Having rapid cycle data has been very important with us, and there are ways of mobilizing or using even birth certificate data in a rapid way, and then using tools that have been developed and shared around the country to do large-scale quality improvement projects. So it's interesting, when you look at the national data, how in 1900, the maternal mortality rate was over 100. And it got down to 7 in 1999, in the 1990s. And people relaxed. Most maternal mortality review committees were shuttered in the 1980s. The problem was solved. And this is what happens when you take your eye off the ball. You can see that the red line here, the US rate, nearly doubled in this time period, 50 to 70% increase. In California, which has 500,000 births, 1/8 of all the births in the US, followed along and was really indistinguishable from national data. And this has really been a push now to reinvigorate maternal mortality review committees and to have them focus not only on the demographics, as I said earlier, but also on what can be done to change. So we partner with everyone, and I'm sure Indiana is no different, with multiple state agencies, hospital associations, different payers and purchasers, physician leaders. It really takes a lot more than a village to change these types make these improvements either in maternal health or infant health. We've been able in California to harness existing data sets. We get feeds of vital records, birth certificates for every birth in California, 45 days after the end of every month. So that's a good base to do quality improvement efforts on, and we link this to hospital discharge diagnosis files. So we have a pretty robust data system at very minimal cost. Now, there's been a lot that you may have read about toolkits, about protocols and safety bundles. So I want to show what some of those are and how they fit into it. So for hemorrhage, for example, there's a soup, if you would, of different medicines or different procedures that can be done. But it takes a protocol or a guideline to organize them into a pattern of response. So it's a start, but issuing a guideline, as our national societies have found, doesn't get you very far. It often sits in a bookcase or sits in a binder somewhere. And so what we are envisioning with the safety bundles that are multidisciplinary and endorsed by multiple national organizations is that they have the support services to put the guidelines into action, to make it easy to work through the communication issues, the teamwork, and the systems learning. But that's not enough too, because the safety bundles are relatively short. So there's a role for toolkits, which are basically resource encyclopedias, where to go to find out how to do the implementation, how have people worked on it previously in other settings, in other states even. And that's been very valuable as you in a health system or a hospital or an office start to try and change things. So nationally, in the Council of Patient Safety, which involves ACOG, A1, the Nursing Association, the Midwife Association, and public health organizations, all come together and made a series of these. And they are not national protocols, but they are advice as to what every hospital in the US should have to prevent maternal mortality and severe maternal morbidity. They're all available free online. We've done a lot of the heavy lifting for toolkits to support it. The most popular one is our hemorrhage toolkit that's been downloaded over 10,000 times, used around the country. But we actually have seen progress with this. So this is a 136 hospital collaborative that we did looking at reducing severe maternal morbidity, major complications from hemorrhage. And you can see in the top line, the purple line, hospitals in the collaborative had reduced it by almost 21%. Hospitals not in the collaborative, the bottom orange line, only reduced it by 1%, 1.2%. Interestingly, you learn by doing and you improve over time. And the middle rows show you the difference between doing it for your first time and doing it for your second or third time. 28% reduction if you were on your second pass and 15% on your first. So we all learn. So let's go back to where we were in maternal mortality in California. Pretty much the same as the US. We started the maternal mortality review committees in 2006 when we saw the rise in maternal mortality, illustrated here, got up to 16.9. 3-year rolling average, it's about 13. But then we started our quality improvement efforts and then our toolkits and collaboratives. And there's been a significant difference in maternal mortality in our state, whereas the US has not seen that as a whole. So we do think there are opportunities to change, and it can be done. But it's not easy work. This was not a single collaborative. This was a whole series of different work efforts here. 3 or 4 different collaboratives. Again, there's 248 hospitals in California. Actually, we lost one last week with the fires in Northern California. One of our hospitals burned down to the ground. But this is work that's ongoing and has to be sustained. So I want to go to another of the videos here, and we're going to take one about hypertension. I suppose the last one is about hemorrhage, but you'll see the themes are similar. So go ahead and roll this one.
You are in critical condition. And the only way to save your life is to get those babies out of you. That's the only cure for what you have. I said, I'm dying, Mom, and I don't care. I said, if I die tonight, then these doctors have to live with the fact that I died and nobody listened to me. And I didn't really mean that I didn't care, but I didn't have the strength in me to fight for, to get me to the hospital. I just didn't want to hear somebody put me down again. They kept kind of like brushing me off. They also kept saying that a lot of this was normal with a twin pregnancy. And the doctor just looked at me and said, I'm gonna be honest with you. And I said, okay. And he said, this is really hard for me to say, but I will have guilt if I don't tell you what happened. When you were here Saturday night, you were discharged without anyone reading your blood labs. And when we saw you just now in the office and we looked at your chart, we saw your blood labs. At that point, you were already in kidney failure, renal failure, liver failure. Your platelets are low. I'm assuming you're gonna need a blood transfusion or multiple blood transfusions. I remember just like this wave of calm, as bizarre as it sounds, and I just remember like going to that safe space and just saying, I don't care what happens to me, save my children. Monday morning, my twins were born at 4 o'clock and 4:01, and I have no memory of them until that Thursday morning when they took me off the drugs. I just felt like this happened to me for this overwhelming reason, and I didn't really know what it was at the time, but like I promised myself that I was gonna do something with this, and I was gonna be a voice that needed to be heard. I'm Melissa Metzler, and I'm one of the 50,000.
The 50,000 refer to the near misses or the severe maternal mortality that happens about 100 times more common, 70 to 100 times more common than a maternal death. So these are voices for which it almost happened. And I think they're powerful stories in terms of, again, how we can do better in our care, in our systems, in our hospitals, in our offices, in terms of working with our women. So I'm going to talk to you just a couple of minutes to show you that it's not that hard with the bundle on preeclampsia. These came out a couple years ago. Now there's growing evidence both in California, Illinois has done a big project on hypertension showing that you can significantly improve outcomes by having standardized approaches to the emergencies of severe hypertension. First of all, women don't die of eclampsia. You may remember Downton Abbey and Lady Sybil died of eclampsia. But that was 1920s. And nowadays, women die not from seizures, but from stroke. And as you see here, this is data from California that's almost identical to that seen in big projects in the United Kingdom, that 2/3 of the deaths from preeclampsia are from stroke. And it is from systolic hypertension. We were all trained in obstetrics and gynecology to worry about the diastolic, the lower number, that it should be, it's emergency if it's above 110 or 105, but now we've learned that it's the systolic, and the systolic over 160. We have a paper in press right now showing that every single mother who died in California from stroke had a systolic over 160. And only one of those had a diastolic over 110, which is similar to the Jim Martin study here in Mississippi. So the lesson is pretty simple. It's treat the damn blood pressure. And that's an easy one to remember, But it's kind of interesting how much barriers there are to actually doing that on a labor and delivery unit. And it's part of quality improvement is doing a barrier analysis to find out the reasons or excuses why it's not done. And there's a whole list of them here, including some hospitals have barriers to giving IV medications by labor and delivery nurses, or the doctor has to be in the house to do that, or they went ahead and give the magnesium to prevent the seizures first, rather than to treat the blood pressure, on and on. And this is part of any quality improvement project in terms of a plan, do, study, act, is to really analyze why it's not being done. But this is the core principle, together with the importance of patient education and particularly discharge education. Now, in the 2000s, most mothers who have seizures or who have, and a number of our deaths are happening in the postpartum period, where they get discharged and get not back to care in a timely way. Now the recommendations for women with hypertension is you should be seen within the week, and we really recommend the first few days to recheck your blood pressure, make certain everything is going well. This is a very simple patient education materials developed by the Preeclampsia Foundation that we've used extensively and highly recommended. So I'm going to turn to some of the national efforts on this. And this is the Alliance for Innovation in Maternal Health, which is part of the safety bundles I spoke of for a moment. And I'm also the implementation director for that, which is why I'm here today. And the AIM goal, the Alliance for Innovation in Maternal Health, AIM, is funded by Maternal Child Health Bureau, but is to eliminate preventable maternal mortality and severe maternity in every U.S. birthing center. So whether you're a small birth center or a large university hospital, there are issues that can be worked on and improved. So it's about partnerships, about providing assistance, implementation, training, and doing a rapid cycle data as much as possible. So our goal is to set up similar processes in every state. And right now we have 20 states working on this, including your neighbors, Michigan and Illinois, that have the same type of model. Public health working with hospitals, hospital associations, professional organizations, and patient and community groups. National AIM is set up similarly, but with the national organizations that can provide backup and coverage to the states as they go forward. The really exciting part, I think, is the sharing among states. In 2 weeks, the CDC is hosting a national network of perinatal quality collaboratives that are working on both maternal and neonatal efforts, and that's very exciting to get. In that case, it's going to be more like 30 states together to share what you've done, to share the best practices that we heard Dr. Box talk about a moment ago among other states, so they can take them and adapt them to their local conditions, but to really be able to use what you've learned from other states to advance your cause. The safety bundles that have been vetted by the national organizations are shown here. The core ones in pink are obstetric hemorrhage, severe hypertension, venous thromboembolism prevention, and safe reduction of primary C-section. In California, we've done hemorrhage and hypertension. We're now working on the C-section project, which is about culture change, shall we say, in labor and delivery. But we're actually making some pretty serious impact on that by pulling everyone together. We have a number of system changes in the lower right for every mother. This includes working on postpartum care, maternal mental health, and reducing disparities. And what we've learned from that is that and I was going to talk about disparities in a moment, is that needs to be part and parcel of every bundle, not off on its own. And just released is the obstetric care of women with opioid dependency, and we'll talk about that in a moment. So this is maternal mortality by race in the United States. Over time, different colors represent different races here. And you'll see the purple line at the top is the one that's so widely separated, and that's Black maternal mortality. Now, infant mortality, as you remember, in Indiana, in the country, is about 2x higher in blacks than whites, and that's a tragedy in itself. Maternal mortality is 3 to 4 times higher in blacks than whites, and that's a disgrace. They all need a huge amount of work. The only group that's even comparable to or approaching that you see in the blue is Native American Indians. And they have their own sets of challenges. But on the bottom side, you can see all of them rising, including the green, which is non-Hispanic white, and Asian. And Asian went down a little bit in the US, but then Hispanics have also risen in this time period, but nothing like what you see with black women and Native American women. We get a incomplete in California, a very definite incomplete, because we see this as well. We saw a fall in maternal mortality, you see in the red line, and the falling from 50 to 26 after rising in the 2000s. But we also saw a fall in Asian and Hispanic women with the ratio you see the dotted line in the middle maintaining at 3 to 4 times higher. Some of the raw numbers. This is a lot of numbers on this slide, but let me walk through it a little bit here. In the red boxes, you see white and black outcomes. In California, non-Hispanic blacks are 5% of our population, 5.5% in here. I think here in Indiana, I think it's 12 or 13%. We only have 29% of our births are non-Hispanic whites in California, which is an interesting comment. Maternal mortality, you can see, is 7 versus 26 per 100,000. And severe maternal morbidity is also twice as high, 2.2 versus 1.2. And then I put in some of the comorbidities, which people always point to. Well, African American women have more obesity than whites, though Hispanics and Native Americans are actually pretty similar. More pregnancy comorbidities, more hypertension and diabetes. Again, American Indians are similar. Maternal age, that's in California at least, that's for whites and Asians, have much higher rates of older moms. And it's interesting that the cesarean rate is higher in black women, both in the total C-section rate and in the nulliparous term singleton vertex, the low-risk first birth C-section rate. It's about 5% higher. Why should that be? When I was a resident in the 1980s, black women actually had a lower C-section rate than white, and that switched over, that line changed somewhere in the 1990s. So why do black women do so much worse? The usual explanation by doctors and nurses, and I would have said this even as recently as a year or two ago, is that black women have more obesity, more hypertension, more diabetes, and more social disadvantages. Okay? So let's look at that a little closer. So what if we looked at black-white disparity in severe maternal morbidity only among college graduates? So black college graduates versus white college graduates, and adjusted for age, BMI, and clinical and demographic factors. So here, in the red column, you can see the relative risk. It's 2.2 times higher in black college graduates compared to white. The black line in the middle is 1. You can see it's 2.2 times higher. So this is college graduate to college graduate. What if we looked at black college graduates versus white women who didn't finish high school? Again, it's 2.4% in black women with college degrees versus 1.6% in white women. So there is something clearly going on in how we work with black women in our systems, how we communicate in the hospital. And this is something we need to be really focused on going forward. This is a really touching story, and I've heard Mrs. Irving, the grandmother here, describe her daughter's plight. Her daughter was Shalon Irving, who had a double PhD from Purdue. She grew up in West Lafayette. She went and worked for the CDC and with a focus on health equities, and was one of the national experts in health equity in chronic disease like hypertension and diabetes. And at the end of her pregnancy, she started getting more and more edematous. She had a successful delivery. And then in the postpartum period, her condition got even worse, and she kept on going back to a healthcare provider and kept on telling her it was normal, the denial and delay that I spoke about earlier. And she passed away 3 weeks afterwards after being seen multiple times in the healthcare system with nothing being done. So not education, not income, not even being an expert in disparities can protect Black women. And you've all seen the stories of Serena Williams that's been in the news a lot. She has a history, actually, despite being a world-class athlete, of having multiple pulmonary emboli. Her doctors and nurses after her delivery minimized her shortness of breath complaints and saying, "You're just postpartum." And she demanded a CT scan. You would think Serena Williams would get her way, but she didn't. And it took many hours for her to finally get it. That showed multiple small PEs and then finally getting the treatment. So it was a close call for a very famous person. One of the things we saw in California was the leading cause of maternal mortality in Black women was cardiovascular disease, particularly cardiomyopathy. It was 4 times higher in Black women than white. And there was a lot of missed opportunities. And the combination of Black race, obesity, older maternal age, and hypertension is really, or 3 of those even, is really a big marker for high risk of cardiovascular disease. So you have to be very sensitive to how respiratory symptoms like shortness of breath. Wheezing. Wheezing is not a sign of new onset asthma, which rarely happens in adults, young adults. But wheezing can be a very important sign of heart failure. So you really need to be attentive to these underlying risk factors and then the symptoms to be able to identify women before heart failure becomes overt. I'm going to turn to a topic that Dr. Box and colleagues were talking about a moment ago, which is the opioid epidemic. This is an interesting slide, putting it in perspective. It's a little faint, but you see in the bottom line, each of these 3 lines, horizontal lines, represents the other public health epidemics in our recent history. So firearm homicides peaked in 1993 with about 20,000 deaths annually. HIV peaked in 1995 with about 40,000 deaths annually. Car crashes peaked in 1972 before speed limits and other safety measures were added at about 55,000. Drug overdoses just in this last decade have overcome those, and in 2017, it's up well above pushing 70,000 deaths nationally. It's not geographically even. You see in this map, Indiana's not in a good neighborhood. How the states around you have very high rates, Illinois, Michigan, Ohio, Kentucky, and the whole Northeast for that matter. And the same states and the same local geographies within a state that have high rates of opioid overdose deaths also have high rates of opioid prescribing, maternal opioid use, and neonatal abstinence syndrome. So they all roll together. And it is very informative to actually do this geography, and we've done this in California, within the state, looking at counties. And I'm sure your Department of Health has done that, but this is very different as you see around the country. In California, we have less opioids, we have a little bit more meth, but it's also geographically quite variable. Our issue in California, though the state's doing fine, is in our poor rural counties, which is, I suspect, what we're seeing mostly in the Northeast as well. What's very interesting about studies on opioid use in pregnancy is that women who are opioid users see pregnancy as a real opportunity to change. They're incented to actually get into treatment. Our challenge is not having enough treatment facilities to work with women. And that's hopefully one of the big changes as we're getting more resources, both federal and state, to attack this problem, that we get enough to work with pregnant women, because this is the group, and all the opioid researchers and opioid treatment facilities say this is the group that is most incentive to stay in treatment for the purpose of their pregnancy and their baby, as every mother is really often focused on their child first. Now, having said that, you can see in this slide, the deaths from opioid overdose are very rare in pregnancy and in the first weeks postpartum. But then it rises dramatically, and here there are opportunities too. This is where women may lose their Medicaid coverage, may not get back into their treatment facility that they were in pregnancy, so dropping the ball between providers. And this is a huge opportunity that we need to focus on. So this is the latest safety bundle. I really want you to focus on a national collaborative that is states working together to share their best approaches and to learn from each other in a national collaborative sanctioned by AIM. And our goals with the bundle are pretty straightforward. Prevent opioid use disorder by reducing the opioids prescribed for deliveries. There have been a number of articles coming out almost really disappointing, really concerning about the amount of opioids used in obstetrics. Obstetrics is the single largest reason for hospital discharge in this country. And these are young women who may be given 20 Vicodins even for a vaginal delivery in some states on average, why should you get any Vicodin for vaginal delivery is a little curious there, but there's opportunities there. We strongly support the recommendations Dr. Box was describing earlier about screening universally. Verbal screening with 5 Ps or the others is a national effort now. But the focus is to really optimize the care of pregnant women. So they have a lot of comorbidities as well, but also through MAT, through medical assisted therapy, buprenorphine or methadone. Buprenorphine, I think, is going to be the drug of the future here as well. But the goal at the end of the day is to create a functional maternal child dyad, not just to get them through labor and delivery, but to have a family at the end of the day. And that's really engaging the mother much more in the care of the baby in the nursery. And there are some very innovative programs around the country now that we're sharing experiences with where babies with NAS don't go to the NICU. They don't need to be intubated. They don't have respiratory or cardiac distress. They need to be cuddled, held, and fed is the most important treatment for babies with NAS. So trying to maintain the mother-infant dyad, which means that everyone in the room here has to work together with your child protective services who in older times would have taken that child away. But if you can show that that mother is in treatment and it has supports, that's where you have the opportunity to keep everyone together. So I'm going to end with these quotes about stigma, because that's really the driver for the care of women with opioid use disorder. It's also true for obesity, mental health issues that we're all struggling with in maternity care. The stigma keeps people in the shadow and prevents them from getting help. And that's really a key principle. And then a reevaluation of addiction disorders. that it's a chronic disease, not a moral failing, and there are treatments that work. And these are quotes from the Surgeon General of the United States. So thank you very much. I'll be around at lunchtime and we can talk then if people have questions, but I appreciate your attention.